All right, so to give a little background on me, I was an imaging manager. I went from being that frontline tech to being a lead tech to being the weekend manager to being the department manager to being a director of multiple facilities to being the director of inpatient and outpatient of 12 different facilities to then working in the C-suite. And then I got voluntold to be an educator. As the first time in my life I actually had a job I never applied for. I didn't. It's a great story if you want to have a glass of wine and chat about it later. I was voluntold my job. I now am the program director for Gurnick Academy's imaging department. My students are all of Southern LA. So at any one time, I have 22 facilities that I work with very closely, as well as 121 X-ray techs who work under my tutelage, and about 35 staff in the LA area, not counting what I do in the Vegas area. I have all kinds of free time, as you can imagine. But I've spent a lot of time over the last 10 years working on trying to bridge the gap between imaging and biomed, because we seem to have these huge invisible walls as if we're not connected when we are so intimately connected. So for my conflicts and disclaimers, because as any good educator, I have to have 2 slides in any slide deck, the conflicts and disclaimers and the reference slide at the end. So to get it easy, I've got no conflicts of interest. My opinions are my opinions, formed through research and both quantitative and qualitative data. It does not represent the opinions, policies, or positions of the ASRT, their board of directors, administrative staff, ICE, my organization, JRCRT, ABHES, the ACR, or anyone else. Now is your time to run away. Too late. All right, so we are going to talk about how financial and operational decisions in biomed and imaging affect patient care costs and efficacy. Now, the big thing is I am very selfish. I realize cognitively biomed covers a lot. There is not a piece of equipment in the hospital or in any medical facility that is not considered biomed, right? Am I correct in that theory? But as a very selfish person in the imaging world, that's all I'm going to talk about is diagnostic imaging, because that's what I know. I understand that, yes, you're taking care of every single piece of every single thing, and that is so daunting. I have no interest. Enjoy your job. It sounds horrible. Absolutely disgusting. I would rather put my hand inside a patient and pull out a bullet and help hold something closed while somebody else sews it up than to try to manage and coordinate all of the things that she described just a few hours ago. Oh, God, no, ew. Doesn't mean I don't have mad respect for it. But for me, we're just going to talk about imaging, diagnostic imaging, radiology, because that's kind of in my head what we're here to kind of connect the dots between. So we need to build a link that removes that invisible barrier, talking about how we're making budgetary decisions, how we're handling downtime, how that affects patient outcomes, and not necessarily patient outcomes in terms of you do or you do not have cancer, but the overarching big picture of their care, from that person in the waiting room who's checking in to when they finally get home, and how long is it until they can get a report. And then how can we collaborate? How can we collaborate, keep costs down, make everybody happy? Much like she mentioned, and I'm going to reference her lecture today, was because it was so good. That, hi, I'm going to add you to the, don't do it shaking your head at me now. It's too late. You're already in the room and I've already locked the door. All right. So she mentioned a lot about the fact that she has a very clear connect to her C-suite, which she was right. We don't all. I have worked in organizations where I had a real clear connect to my C-suite, and I've worked in organizations where they were so far removed, I don't even think they knew my face to go with my name. And this is not a hard look to forget. But I don't think there was a real connection to seeing me in the hallway and then connecting to what I did for the organization. And that's got to make a big difference in conversation, not just a number on a piece of paper. And when we have downtime, which I think is the biggest issue that we have, when we say hi, we have to go on divert because our CT is down. Does that mean something to the C-suite besides we're losing revenue? Or does that mean something to the C-suite because they are connected enough to go, how many patients were we not able to serve? And in your organization, I don't know how to tell you to connect those dots other than communication. Like I tell students every day, everything we do is about communication. Every person in this room's had an x-ray, right? In their one time in their life, an x-ray of some kind. Has everybody ever? You have never had an x-ray. You are fired.
Oh, let's go.
Yeah, let's go. Come on. There's some portables downstairs. We can make some magic happen. But realistically, most of us know that when we start working with a patient, the first thing that we do is communicate, right? We don't touch them at all. It's all communication. Hi, I'm Nick. I'm here to help you. We're going to go ahead and get some imaging done today. And between the two of us, we're going to get some images for the radiologist to view to get a report to your doctor. And if we do that communication right, down at the patient-facing clinician level, then we become a member of the care team and the patient is a member of the care team. It is you and I working on a shared goal of that image. It's not a you and I adversarially, or it's not me versus you to get an x-ray. We're not duking it out. It's what can I say in less than 30 seconds to put you and I on the same team with that goal together. Finding a way as imaging leaders and biomed leaders to do that same type of conversation with the decision makers and with each other is kind of the end goal here. I can't sit across the table from biomed, and I don't say it just biomed like it's a negative thing, it's a great thing, but I can't sit across the table from biomed and go, why isn't this working better? I need a new piece of equipment. I want it on your budget. No, I want it on your budget. No, it's got to be on your budget because I'll never get that capital approval, but you have to put it on your budget. All of a sudden now we are not having the same goal. It needs to be a you and I, what are we going to do towards this common goal? Because then we are creating buy-in, right? We've all learned about creating buy-in for a project. So that's kind of in the end, if I can figure out how to help you create some buy-in and some tools to help you create buy-in, yay, we have been successful. All right, we have a lot of boring slides, by the way, coming up, so grab a cocktail. Yeah, it worked. Wow, hi, we missed a lot. That was a very fast lecture. The hell? Okay, okay, and that. All right, we talked about how our budgets could need to align. We talked about a little bit how we need to affect patient outcomes and collaboration. Some of the research I did, I found fascinating was that there's a massive cost when our equipment goes down, lost costs. And as imaging leadership, we don't understand that necessarily from the biomed perspective. Real quick, how many imaging leaders are in the room and how much are any of you imaging leaders? Sweet. I'm alone. It's okay, I can take you. I'm snarky and I bite. So, all right. So what I find fascinating is when we have a loss, it can affect almost up to $300,000 annually per facility in revenue, and downtime affects revenue, right? So that sucks. It is low, but I'm thinking for smaller like outpatient facilities, because a lot of the data I pulled from when I was managing 12 outpatient facilities. So per facility, now one of my facilities, I saw more patients than most rural hospitals did in a single day. And we saw 750 patients a day without a blink of an eye in Vegas. So, but downtime makes a huge difference. And preventive maintenance, it reduces downtime. Yeah, well, isn't that no, not even bad. We are, I'm a firm believer that we need to communicate together. It's like I teach a lecture hall of students. If we're not all talking, we're not all learning, right? I can't learn from you, you can't learn from me. And I'll make you roll for initiative if that means I have to get, that's the only way I can get you to talk to me. I'm a geek, we play D&D. All right, so how are you communicating that with your team? So again, we're just going to kind of think imaging, not nursing and the snot suckers and the, all the other departments in the hospital. And I mean, I'm sure there's even biomed in facility maintenance for all I know. I don't know, not what I do. I handle CTs and MRIs and mammos and 3 different kinds of ultrasound machines and 3 different kinds of MRI machines. And that's my world. So that's kind of what I think about. And then with working together, we need to realize that patient care is everybody. It's not just those frontline clinicians. If my machine is down and biomed is involved in helping me get it working again, well, I can't see a patient until we get it working again, right? That means my patients are delayed and you are just involved in that conversation. You might not be the one calling the patient and saying, I am really sorry, our CT scanner is being worked on in the moment. We're looking at a good hour or so delay, or can I reschedule you for tomorrow or the day after, and what does that look like? Have any of you ever been around when that phone call's been made? No, it's not in your scope of practice, technically, right? But that doesn't mean that you aren't intimately involved in that conversation. So we're going to talk about some cost-saving strategies for equipment longevity, repair and replacement decisions, and how are we budgeting for that, and how are we proving we need it. There's something to be said for going to the C-suite and saying, I need it. I want a new CT scanner. What's the first thing that you hear? Come on.
Can we get about
Can we extend it? Or what else?
No.
Just flat out no. I hate that word. God, I hate that word. And I'm not a good enough person to be able to turn that no into a yes that by myself yet. But another thing that we absolutely hear is why? Prove it. Give me a good reason. You've got a perfectly good CT scanner down there that we bought 10 years ago.
Keyword, you said 10 years.
Mm-hmm.
Technology's changed.
Of course. But you got a perfectly good CT scanner and it's paid for. And you were scanning on it today. Why do you need a new one? There we go. So we got to figure out how are we dealing with those constraints that we're being given, those handcuffs that we have, and how that budget needs to be including everyone. So if I'm looking at my capital budget, I think you mentioned, oh yeah, I'm going to keep calling you out. You mentioned that you meet with your departments annually. What about the rest of you? How often do you meet with your imaging department about their budget? No, it really, I don't think it is the norm, and I think it's great that you do, though. What about you, Bruce? How often? Is it budget season?
It's more budget.
It's budget season, tends to be budget season, because we're both trying to build our budgets, right? So it's budget season. I would recommend that you sit down with your imaging leadership, your managers, your directors, not just the directors, the managers as well, at a minimum quarterly. How's yours? And with data in hand, these are all the things that I'm seeing that we've done repair-wise on your equipment. How are we tracking how the patients are being affected? Hospitals are living and breathing by patient care scores. Press-Ganey, Sullivan, Llewellyn, how often do you hear the phrase Press-Ganey in your facilities? Because reimbursement's tied to it. If you want to catch a hospital in the pocket, get Press-Ganey involved in the conversation. It's 100% true. Because Medicare and Medicaid's reimbursement is based on Press-Ganey scores. And if you think private insurance is going to pay more than Medicare or Medicaid will, if they don't have to, of course they're not going to. Why should they? Not significantly in any way. So keeping those Press-Ganey scores, that patient care involved in the conversation helps to also push that needle of how are we going to get that new CT scanner that's 10 years old that, yes, I was scanning on yesterday, but you know what? Why should a patient come over here to get their study done when they can go down the street and get a study done on a brand new scanner with better technology? Don't we all like to stay at nicer hotels than cheaper hotels?
But they're looking at throughput too,
They're looking at throughput too.
because that's,
So I'm going to skip ahead a little so we can actually, I like leaning into that. Yes, I know, I growl like a pissed off chihuahua. It's okay, you'll be all right. All right, so I'm going to skip ahead a little bit because I like where we're going with throughput, because we have the shared goals. We already know what we're talking about these things, and we're going to learn from different lessons in the past. One of the things that we can do is how are we tracking data? Your tracking is phenomenal. Your tracking is that did everybody go to her lecture today? You should have if you didn't. She has some fantastic Excel spreadsheets that she uses for tracking quotes and billing and purchasing and such. But at the department level, you're probably hearing or seeing tracking about patient turnaround time, how many patients that we've lost because of a system being down. And if they're not tracking it, I suggest that you talk to somebody about tracking it, because that's the quantitative proof that you need that says we need more resources, whether it's another FTE, whether it's more training for your in-house biomed teams to be able to keep things running more efficiently, and some ways of doing some of that tracking to support the decisions that we're trying to make. Just as an example of some facilities that I tracked, this is how long it takes to reschedule a study. If I lose a CT scanner and I have to reschedule somebody who was supposed to go to C-Rock, and let's see, a CT without, it'll be 13 days before I can get them back into the schedule. Yeah. And if that, and we'll talk about it a little later with a mammo example, but if that patient has a CT and a chest x-ray scheduled at the same time, and they got canceled for their CT without, they're not going to still drive over and get their chest x-ray done. They're going to wait. So you've lost revenue on 2 studies. Or that CT without, although, yeah, they're scheduled at C-Rock, they live a block away, they really wanted to go there for their care, but I could tell them, but wait, we could see you over in Pahrump or at Palomino tomorrow. But that is 35 minutes away on the other side of Las Vegas. And I don't know if you know much about people who live in Vegas. We don't like to drive across town. I mean, even when we feel California's earthquakes, we'll wait. It is not fun, but it makes a huge difference. And we're looking for mammo going down. And this was 1 day snapshot. Mammo was down. It was 43 days before that person could get back into Horizon for a mammo. Yeah, so tracking data like this. I mean, obviously some of these are like ultrasound breast and stereo. We don't do those at the facilities that are Black, but you get the point. We have other options we can give a patient, but that is also patient care. I want to go where I was seen before. I want to go where my records are. I want to go where I know the tech. I want to go where I did all the prep ahead of time and all the lab work ahead of time. But as one snapshot of one moment in time, a down machine can affect care.
it can also affect surgery because you need a CT.
Yeah, you got to have that pre-op chest x-ray, right? You got to have that CT done, right? So another moment in time was something else that I recommend tracking, where we could see, okay, when I say hard down or restricted, how many hours they're down. Restricted for MRI, say my breast coil is down. I can't use the breast coil, but I can use the machine for everything else. That's a restricted unit, okay? And hard down means it is down, it is dead, call a code, grab the morgue, it ain't going nowhere. But how many, and this being able to show month over month, and more importantly, year over year, green being it got better, red being it got worse, I could say, you know what? I was, for example, MRI was hard down for 7 hours. It was restricted for 18. I had to reschedule 7. It affected 17 patients. 17 different studies had to be moved, adjusted completely. CT was hard down for 20 hours. It affected 37 studies. My favorite is here. X-ray, one of the rooms was down for 75 hours. We had one restricted. It affected 277 patients. We don't think about that in both sides of the aisle. Oh, we're just down for a few hours. They can still use the room. It's okay. Not necessarily. And we may have 2 X-ray rooms or 5 X-ray rooms. But one room being down still affects 277 patients. I just need to get a new tube in. The collimator light. If you could ever do an in-service for your X-ray department, if you ever want to do an annual training or an in-service, talk to them about being able to teach them how to change their own collimator light bulbs. It is not that complicated to do, right? But at midnight, 1 in the morning, 2 in the afternoon on a Saturday, when there is nobody around, and their trauma room collimator light goes out, and they are not gonna, only an old school tech is gonna continue to use the room. When I went to school, we learned how to shoot without that collimator light. But they're gonna go to another room to use it. And that's maybe not the best room. It's not gonna be the newest room. It's gonna be a room they don't use as much, not as easy for traumas to get that gurney in and out of. Do an in-service. Teach them how to change out their collimator lights. Make sure they have a supply of collimator lights somewhere. Wouldn't that make your lives a lot easier than coming in on a Monday morning or first thing, the collimator lights out, come somebody fix it. And then having the departments track both through. This one happens to be from 2019 because I had to wait long enough to get permission to use the data. But the communication is the same. How many studies are we doing a month? This is one outpatient facility. How many studies are we doing? We can see the fact that we could say, you know what? Come on. I'm down or I'm not down. It's affecting that many people. We see that many people a day or a month. When we are down for just a small amount of time, it does create an impact. We can compare those months, those numbers with when did I see the least amount of patients? I like a good quantitative data. That's why I do spreadsheets so much. I'm really going to use that like Monday. You don't even know. I want digital equipment. I want full DR. I'm going to get it now. You don't even know. I'm going to be getting me some digital equipment, and next year you and I are having cocktails. All right. So financial impact, we talked a bit about that. What do your budgets look like? Now, I learned a little bit a few hours ago, but your budgets are not like our budgets. We have the most expensive equipment in the whole hospital, and we know it. And we are very prideful about it. That's why you could never convince me to be a nurse. We build hearts out of ones and zeros, people. Come on. We need to have the good equipment to do it with. Do you know what your imaging department's budget is at any given time? After budget defense, after budget season, do you sit back down with your imaging leaders and ask them how to go? What were you approved for? What did they say no to? Did they tell you we can't do it this year, but maybe next year so we can start pre-planning for next year? What about your budgets? Do you share your budgets with them? This is what we were approved for. We asked for more training for your department, for your equipment. We asked for more We tried to beat on the OEMs that when they come out to train with our people, because I know that's an issue. If you weren't getting it, have you gone back to the department manager to say, you have a relationship with your OEM? They kept taking you to lunch to try to sell you on their CT scanner, right? You've got the relationship more than we do in some ways. They want you to be happy. They tolerate us. They don't want our happiness. They want to be your one and only shop for everything. Did you lean on them about training? Could you maybe consider doing that? Help your budgets out. So just some basic graphs because, graphs are fun. So your budgets versus our budgets. I don't mean to depress you. But if we work together without sharing, we're going to spend a lot more money than if we do share data. And are we working together? Are you working in facilities that have multiple locations? Kind of like I had 11 or 12 locations. Are you pooling budgets for service? Because you're servicing everybody, right? Are your budgets just for one facility? Depending on how your budget department works, or are you getting a budget and hi, here's a $10 bill. That's what you get for all of our facilities. Have a good time.
And then we need the line of sight.
Yeah, you got to know where your money's going. How can you be expected to be accountable to a budget if you don't have line of sight on it?
Oh, it happens every day.
Of course it does.
Like usually half of our community has accountability, but no choice. So that's standard operating.
100%. How can we, and it's not fair and it's not right, but how are we having that conversation with sharing those budget? It comes down to communication, sitting down, creating that buy-in together towards a shared goal.
And that's it.
I'm done.
That's all she wrote.
No, I wrote other things. I wrote a lot of other things. Well, by the gods, hello. There's another slide over here. Let's see what happens if I do it manually. Everybody come snuggle. Cuddling is friend. All right, so again, just like we were talking about, it's all about cost reduction. I want to be able to, you got to be able to reduce costs with a better goal, which is of course what they've been asking for, right? Reduce cost, better goal. I got it to work again. And then these are our major challenges. Funding, where's the money coming from? Training, getting that training between, because the OEMs don't want to train. 100%. They have there's no ownership in doing that. It is going to work against everything they want in their world, but it's always, usually it's in our contracts that training will occur. Are we fighting for that? Or are we just making it, hi, I'm down, Bruce, fix it. Okay, let me call. That's how I measure it. And that is how no, seriously, that is how I hold them accountable, because I force them to meet with me quarterly and say, and when we've had service providers, a service contract outside of the OEM, I have, because we'll keep the OEM for the first year because, well, why not? It comes. But in that OEM contract that I have then managed by my service provider, I make them meet with me quarterly, and they're so proud of themselves about, oh, well, we didn't have much downtime and we had the equipment was running. And I walk in and I go, please hold. And I opened up my binder. Here's all my data. I've just emailed it to you as well. Send. Your numbers are wrong. We were down here. It was this many days. I can track the service calls, and I have more spreadsheets that I track when I called, who we talked to. I track it to the walls because I love quantitative data. And I could say no. And they look at it and go, you know what, you're right, Dr. Walton. We need to adjust our data. We will get new of these documents back out to you later, because I will hold them to the wall, and I hold them to the wall because of this. I can full on in the moment to the day, the minute I call in for service, because they have that lovely website that they want me to use when I need service. Well, I can go back and check my logs there to know exactly to the minute when I reached out to them that the system was down. And my system is not down from the time they finally come out, look at it, diagnose it, and then tell me it's down. It's been down since I made the phone call. Right, but from the second I found out about it is when then that phone call's being made. That's the number I fight to be the one that's included. It's not when they finally come out, they finally take a look at it, they finally diagnosed it and come to my office or call me and go, Dr. Walton, the system's down and we're gonna have to order an XYZ. That's not the minute it's down. The minute it's down is then, and that's what I'm tracking. And that's what I force them to be accountable to, because that is not the number that they will be accountable to if I don't. So yes, I track it.
It's how you comparing that to have to do a software update or something to take the system down.
Stuff like software updates, PMs, things like that.
Stuff that's, it's not.
Planned, yeah, planned is different. Planned is different, and planned well, I love that you like looked at my slide deck before today and we're like, let's chat about that too. Planned is different. Planned is something that I've worked very hard with my teams. So we've talked about money. We'll talk about how it affects patients. Planned is a different issue. Planned is something that you need to work with your Biomed or your OEMs or your whoever and say, cool. And it can be in the contract, which is what I've always done is put it in the contract is my PMs, my service, my physicist who comes in to make sure that what you did is right. All of that happens outside of the generally busiest times of day. For my outpatient facilities, you get to come in Saturday at 5 p.m. Or if it's in my hospitals, you get to come in Saturday at midnight or 11 p.m. That's when you can start. And you can start on all the other rooms. And when they're all done, then you can use this one room. Because I know, just knowing my patient population, I'm not going to be so busy between 2 and 3 in the morning. And it's going to take you that long to get the other 4 rooms done before you actually get back to room 1. But that's required. They cannot come in and do service between 8 a.m. and 5 p.m. Monday through Friday, or 8 a.m. to 5 p.m. on Saturday, because my outpatient facilities are open. For MRI, they can't come in until 11:30 at night, and no sooner, because we're running MRIs till 11 at night.
So I'm curious, how many?
I can confidently say, with confidence, that every imaging manager in Las Vegas, Henderson, Summerlin, Centennial Hills, the whole bowl are all doing this now because of the work I've done. And a good chunk of the center and slightly to the right of New Mexico, everything in the Presbyterian healthcare system, which kind of hits along the center of the state coming down, because that's where I started working on this work before I transferred myself to Nevada. I will give you my card. I will for free give lecture and teach anyone you ever want me to.
The 3 of us just need to take over.
Just waste it. Yes. I'm a firm believer of surrounding myself with people smarter than me because it makes me look good. She's smart. All right. So how is all of this affecting your patients? I'm going to tell you a story. And if you're in this room in an hour, which will be a different fun experience, you repeat after me. I will not share the story. That's right. All right. So a little bit about Maslow's hierarchy of need. We've all went to school a long time ago. Do we remember Maslow's hierarchy of need? I can't do any of this if I'm not doing this, right? There's the basics. I was a brilliant, so smart, 19-year-old kid. This was my car. My father got me a car to drive. It was his car. He owned it, but it was my responsibility to take care of this gorgeous, stunning Chevy Citation. I know, right? Windows, you had to roll. It was a workout. Right? This was my car. The day I bought that used baby, that gorgeous hunk of machinery, I was the envy of all. Woo! I was going to work at the mall back in the day when you worked at the mall, because that's where the jobs were. I went to go to work at the mall. I got up early. My car needed gas. I was responsible. I got up early enough to go get gas and not be late for work. I was riding high up on my Maslows. I was ready. I was going to be on time for work. I was dressed appropriately. I had a car. I was going to get gas. I thought of it myself. I go to get gas. I look down at this front tire. Oh, wait, hold on. At that front tire right there, it was really low. I knew nothing about PSI. I knew nothing about if you open the door, there's like a sticker in there that tells you what the number is you're supposed to do with your car. I was an 18-year-old kid. I was responsible though, and I put air in that tire until it looked full. Yeah. So this is New Mexico. This is the high desert. It is cold in the morning, and then it heats up and gets real hot during the day. I had gone to work at 9 a.m. I wasn't getting off till 3 p.m. But I'm at work. I am here. I'm responsible. I put air in the tires without having to ask anybody. I got gas for the car. I parked it in the parking lot. I went into work, had a great day at work, came out of work, 3 in the afternoon. It had increased by 70 degrees in the day. As I stepped out of the mall, the door shut behind me, I watched this tire explode. It took this entire quarter panel, flung it across the parking lot, and wrapped itself around a light pole. The whole front end of the car, I went from here to there because I had to call my father and tell him that I'd blown up the car because I didn't know how else to describe it. So I went in and grabbed the payphone that's right on the inside of the exit to the mall because it was the mall and it was the 80s. Get over it. And I called my father. I'm like, Dad, I blew up the front end of the car. I'm sorry, you did what? I blew up the car, Dad. You're going to have to come get me. There's no more tire or front end or a whole piece of the car is wrapped around a pole over here and I can't get it off. He said for the many years he worked in as a mechanic, worked in the toll booths, collect race cars and sports cars. He had never heard of anybody blowing up the front end of a car that I was able to manage. That's my fun, moving from the top to the bottom. That was just a car. Can you imagine I have to go get an x-ray because I have to have surgery and I'm scared and I'm never going to walk in that door ever in the hospital at the top of my Maslow's hierarchy of need. I almost aimed it perfectly without looking. Did y'all see that? I'm going to have to practice that. But I can guarantee you not a single patient who walks in the halls of your hospital is at the top of their Maslow's. Not one of them. They're all nervous or scared. There's a reason they're there. People don't go get x-rays or CTs or mammos or ultrasounds because they're bored. We don't make a list. I got to go to the grocery store. Screw that. I'll have Instacart deliver it. I gotta go drop off some boxes and make my returns at Amazon. I gotta go grab, I need some Starbucks. I'm bored. Let's go get a chest x-ray. It doesn't work that way. You come for a reason. So we're already not starting real high. And now I'm walking in and what do you mean my machine's down? The machine's down. Or what do you mean there's a 4-hour wait in the waiting room that started 5 hours ago because something went down on a piece of equipment that needed to get fixed, which snowballed and delayed care, right? So we talked about minimizing downtime. We talked about moving our service time to off hours, and please teach people how to change a collimator light. It is such a big deal. Y'all don't think about it much, but it is a massive deal for a tech if the laser light goes out or the collimator light goes out. That room is dead to us. We can't use it. Can, but they're not gonna. We had in one facility mammo go down. It was all of the diagnostic mammos. We could not do a single one. These are patients who they've had a mammogram. It came back with a question. They had to come back for diagnostic study. And usually that diagnostic study also included an ultrasound breast. They kind of go hand in hand. And if they were there, they might as well get their bone density stuff done too. And potentially a pre-op chest x-ray, depending on what the radiologist saw, just to be proactive and plan ahead. Or an MRI of the breast, depending on that situation. Mammo went down for 2 hours. It forced a reschedule of 20 appointments. These are 20 people who could not find out whether they had cancer. Because the schedule, and you remember far back how busy, how many days it would take to get back into the schedule? Yeah. At that point, for that 2 hours, it was 14 days before they could get back in anywhere in the system. Because Mammo had gone down in another facility and had already filled the schedules of the other facilities before mine went down. So now we have a huge snowball effect of patients who can't be seen. And if they're not coming in for that, they're not going to get anything else done. So all those other studies were canceled. So the revenue of all those other studies were canceled. Now at the time, and I will throw down bad management if I have it, we had just been bought by an outside organization. And that outside organization's only intent was you make money. They cut down the schedule for a CT that would take 20 minutes, they cut it down to 15. And we're now scheduling patients every 15 minutes. They refused any overtime or anything. Overtime was completely denied. And in this situation, it was the situation that ended up making me walk away and resign. It's the only time I ever resigned from an organization was because of bad patient care. Is they said I had a mammo tech who had been off of work on Monday for doctor's appointments all day. She offered to come in on the next day, the day after this, on Saturday, to take all those patients the next day. She would have only ended up with 2 hours of overtime because she missed 6 hours in the week. Win-win, right? Was vehemently told no, she may not do it because that's 2 hours of overtime. Yeah, exactly. And then that is exactly the reaction I had. And when my voicemail as the manager of the department got full of 22 messages from patients who were livid that they weren't able to be seen, I forwarded every single one of them to the C-suite. I'm a hateful person. And then I walked in and went, here's all the numbers. I ran the numbers here because I love a spreadsheet. Here's all the revenue that we lost because not only did they not come in for that, they canceled all the other studies. Here's the patient care. Here's the Press-Ganey scores that are going to come from it. Here's everything that went wrong by the decision that you forced down our throats. And also, how does that look for the techs who are trying to do the right thing and they love patients and they love what they do and they understand the impact of what they do. And now as a leader, I'm telling you, what you care about does not matter. All we care about is the money. No, you may not work. Think about that from the frontline clinician's perspective. Now I'm working for an organization that doesn't care about our patients or me.
The thing about it is they didn't think from a managed standpoint of contingency plan because everything's not perfect.
No.
You don't have a contingency plan. I don't care if it's a clinic or a main hospital. You can't predict when something's going to go down.
Right. Things are going to go down. They're just going to go down, but you got to plan ahead.
Right.
And you have to be willing to give a little flex when that happens. And I ended up walking into the COO's office the next day with these charts. I'm like, here's where we made a mistake. We cannot do this again. And his answer was, no is no, no overtime. That's just the way we do things now. And I went, and I guess that's not the way I can do things. This is not taking care of people. It was the biggest regret of my career because I mourned the loss of the people who I were caring for that I now no longer could care for. But I could not work in an organization that ethically, that's not why we go into medicine, right? Ugh, it was awful. Going home that day and explaining that to my husband was fun. But alas, Biomed plays a critical role in patient care. It affects our patients. Do you, and I just don't know, so I need y'all to answer, when you're roaming around the facility, when you're doing your thing, when you're over in the imaging department, do you have a program where you sit and spend a couple of hours in the imaging department so that you see what your work is doing? so that you see how the effect of that machine is on a patient, whether it's an MRI where they're terrified of it, or how it's being used by a tech to help a patient. Are you able to spend time watching your impact, your team's impact?
I think it's a little different department. They understand.
Are you ever in there when the equipment's working?
Right.
That's what I wonder. I know that you guys are getting there fast.
No.
Are you in there when the equipment's working? Are you even just standing in the bridge?
Take this time.
Do you understand the importance of the collimator light?
Right,
Is it just a light to you?
right.
Do you understand what we use that laser for? What we use that collimator for? How it affects patient dose? Do you know that that collimator light affects patient dose? Yeah, I think
Gotta account for some of
I agree. I mean, it's so easy to just, I was in my lift yesterday, I couldn't speak Spanish, so I used Google Translate to tell the guy I would appreciate the fact that he was using a Rubik's Cube.
Puts most together.
Exactly. And having that take an hour every 6 months and go find a modality to sit in for a bit and just watch. How are they using the equipment that you guys are maintaining? Maybe they'll treat it better too in that hour. Again, it's all about knowing what the importance of that collimator light is. Why do we care about the laser? We need it for positioning. We need it to reduce dose. So I've realized that we've run out of time. And the big question that I have is what I want from you is I teach x-ray techs. I teach x-ray techs and I teach baby fellows how to basically read an x-ray. This is a chest x-ray, airway, breathing, cardiac diaphragm. But more importantly, I teach x-ray techs. I'm teaching 200 students a year. What do you want them to know about you? I talk to them about Biomed because I have a passion for it and creating that connection between our teams. What do you want them to know, to learn?
Right.
Yeah.
So think about how we're guiding our financial and patient care choices, like we're talking about teamwork, and then making sure that we can work together on those financial decisions to help with getting that CT scanner, getting another FTE in your department or ours, doing cross training, making sure that you're getting the training that those OEMs promised you would get. Because I'm a bitch. I'm
And making
full
sure
on.
you get the follow-on clinical.
Yes.
Because guess what? You have new staff from the day that it was.
Exactly. And there's my resources, my references, because, you know,